Ladies and gentlemen, with excitement and a little reluctance, I'll ask you to cease your conversations and assume your seats. We have a general rule here that if there's a seat that's empty in front of you, you should take it, so that we don't have empty seats up front. Minister Philpott, welcome. Our partners in this event, the leadership team from the Lancet and the University of Toronto's Faculty of Medicine, friends, colleagues, ladies and gentlemen, good morning. My name is Khalil Sharif. I'm the Chief Executive Officer of Aga Khan Foundation Canada. And it is a very special delight this morning to welcome you to the delegation of the Ismaili Imamate on these traditional lands of the Algonquin people, who for centuries gathered in this place where the three rivers meet to come together and exchange goods for sure, but also relationships and conversations and ideas. And it is a very special privilege to be able to, in our own way, continue on that tradition, that great tradition, here with you in this space. We are gathered at the delegation, for those of you who have not been here before, which was established by His Highness the Aga Khan some 10 years ago now, as a symbol of the important relationship that the institutions, the global development institutions of the Aga Khan Development Network had established with Canada and Canadian institutions, and the important future we felt we had together to work for the improvement of the quality of life of marginalized communities in Africa and Asia. When this was established, His Highness has articulated the aspiration that we might use these public spaces to host conversations that will lift our collective horizons about Canada's role in creating a more peaceful and prosperous and pluralist world. And our partnership today with the Lancet and the University of Toronto is a fitting example of exactly that ethic in action. The Aga Khan Development Network is a family of some 9 or 10 global development agencies, of which Aga Khan Foundation Canada is a part. We have had a long history of work in global health. The Aga Khan University is started its life as a health sciences university, an academic medical center in Pakistan, now in Kenya as well, with teaching sites in several other countries around the world. The Aga Khan Health Services is a very large provider of not-for-profit health care in the developing world. The Aga Khan Foundation, for decades, has been working in some of the most remote and rural areas of the world to improve health outcomes for communities. And we've been delighted that so much of that work in health has been a collaboration with Canada and Canadian institutions, both the Government of Canada through Global Affairs Canada, but also a number of extraordinary Canadian individual health leaders, who I think those of you who are in the field know that Canada is overrepresented in the global health leadership workforce, and that's the same with us in the Aga Khan Development Network, but also with Canadian institutions. Our universities, our professional associations have been an extraordinary source of support and thoughtful leadership on these issues for many, many years. Therefore, it's been a particularly exciting moment for us to be able to partner with the Lancet and University of Toronto to host this session, which is the launch of the first ever series that Lancet has done on Canada. And I wanted to just identify 2 or 3 things about the series and about this collaboration that has made it particularly important for us. The first is it's always a delight for us to be able to mobilize a global institution like the Lancet to look at Canadian issues and to bring the best kind of analytical and research minds to bear on the issues that we're confronting here in this country. And so this is a great example of exactly that happening, and the way the Lancet has mobilized an extraordinarily diverse range of Canadian research capacity to contribute to this series is itself, I think, an important achievement. The second one is we're so delighted that this series brings together in a single volume a sort of bifocal vision, looking simultaneously at Canada's institutional capacity in its own healthcare system at home, as well as looking at Canada's history and potential as a global health leader. And it's our view that at Aga Khan Foundation Canada that we would like to think about this across all kinds of sectors. What is the relationship between our domestic institutional capacity in a number of sectors and the implications for global needs and global leadership? We think this is relevant in the K-12 education sector. We think this is relevant in advanced and higher education. We think it's relevant in pluralism, which is an area where we've thought about a great deal, where Canada's domestic achievements and fragilities have an implication for the world and could inform in an important set of novel ways Canada's global leadership role. And finally, of course, it's an extraordinary example of mobilizing research, science and evidence and thoughtful perspectives to inform the actual conduct of our affairs, both at home and in the world, which I think we can never do too much of. So it's an extraordinary delight and privilege for those, at least for those three reasons, if not more, to be able to be partnering with the Lancet and U of T in today's event. We've got an extraordinary morning organized and planned for you today. And to start us off with the program, I want to invite one of our important partners, Dr. Lynn Wilson, the Vice Dean for Partnerships at the University of Toronto's Faculty of Medicine, to join us to say a few words. There she is.
Thank you, Khalil, for the introduction and for your very thoughtful remarks and for hosting us in this spectacular facility. I'm delighted to welcome everybody here to this exciting event on behalf of the University of Toronto. We're quite pleased to be partnering with the Aga Khan Foundation of Canada and the Lancet to launch this truly special issue, which critically examines health in Canada and Canada's role in global health. As Canadians, we take pride in our healthcare system and our leadership abroad, but as this issue reminds us, our pride cannot make us complacent or blind to areas that need improvement, such as delivering health services to Indigenous communities. And it's also a reminder of the importance of studying and evaluating our health systems and the need to engage policymakers and leaders in analyzing the results that they can take informed action. So that's why I'm glad that we're holding today's event, so that you can learn about the findings detailed in this issue of the Lancet and deliberate on the ideas it raises. I'm also very glad that we'll be hearing from the Minister of Indigenous Services, the Honourable Jane Philpott. Jane is both a physician and an associate professor of family community medicine, yay, at the University of Toronto. You can tell I'm a family doctor. I'm very proud of U of T's contributions to this issue. The lead authors on the two commission papers are Dr. Danielle Martin and Dr. Stephanie Nixon, who are both U of T faculty members. And the editor of this special issue, Dr. Jocelyn Clark, who's the executive editor of The Lancet, is a U of T alumna. She completed her PhD in the Faculty of Medicine, and fortunately for us, Jocelyn is a U of T faculty member. So Danielle, Stephanie, and Jocelyn and their collaborators embody our commitment to national and international leadership through both scholarship and discovery. When you leave here today, I hope that you'll agree that despite our successes, we have to be more innovative, be more efficient, use research more effectively, and most importantly, we must stay focused on the most vulnerable amongst us, including our Indigenous peoples. I also hope you'll share our commitment to finding new solutions that will ensure better health for everyone, both here at home and around the world. So I'd like to thank the authors, the Lancet, the Aga Khan Foundation of Canada, and all of you who've partnered with us to support this effort. And most importantly, thank you to all of you for making the time to be here this morning. And now it's my pleasure to welcome to the podium Dr. Richard Horton, Editor-in-Chief of the Lancet. Richard?
Bonjour, bienvenue. It's a pleasure to be here today. Thank you for coming. Canada is iconic in health and global health, and today is a moment to recognize its iconic status. You as a nation were responsible more than any other nation for the birth of the notion of peacekeeping. 0.7% would have not entered our lexicon without your bold leadership. The Laggard report and the Ottawa Charter are defining documents in the way we think about health in the 21st century. Evidence-based medicine was born in Canada, and I had the pleasure and the honour in a previous administration leading this country of seeing how Canada's soft power leadership in the area of women's and children's health through the Muskoka Initiative really mobilized nations. When you had a G7 head of state taking an issue and leading with it, other nations followed. And Canada's commitment to women's and children's health through Muskoka was a transformational event in the history for women and children. You've had iconic leaders, and you have them today. Emily Howard Jennings-Stowe was the first woman doctor to practice medicine in Canada, and we should recognize her incredible achievement. Jenny Robertson, the first female surgeon in Canada. John Evans, Brooke Chisholm, who was the first Director General, Dave Sackett, and Monique Béguin, and I'm so sorry that Monique can't be with us today. You have world-leading institutions that make an impression in global health, just to mention two, IDRC and CIHR. And you've already heard about the University of Toronto, but you actually have 4 universities in the top 100 in the world: Toronto, UBC, McGill, and McMaster. Your intellectual power and leadership in the world is immensely strong. And so in so many ways, health and medical science have been part of the foundation for the building of this nation. Now, writing in this special issue that you have in your hands, I hope, Prime Minister Justin Trudeau describes a truly inspiring vision for Canada's leadership in global health. And I really want to underline my personal admiration for a vision that puts this totally original notion of a feminist international assistance policy front and center of its development initiative, focusing on, and bravely focusing, because so many nations do not, on sexual reproductive health and rights, empowering women and girls, addressing gender-based violence, child marriage, female genital mutilation and cutting, and radically repositioning, truly radically repositioning Canada's aid budget to meet those commitments. And yet, and I say this as an outsider, that powerful and that progressive, much needed message arrives at a moment of paradox. In the airport yesterday, as I got on the plane, I was given a copy of Wednesday's Globe and Mail. And in that newspaper, a respected Canadian scholar on international affairs, Valerie Percival, wrote a powerful, heartfelt column in which she criticized the government for failing to prioritize global health during the G7 process in the year of Canada's presidency. She wrote this: "While our rhetoric shines, our promises are beginning to sound hollow." Now, I am not a Canadian, I am an outsider, and so it's impossible for me to judge who is right. The government claims powerfully that something radical is changing in Canada's direction of travel in global health and development assistance. Some observers are raising questions about how serious that commitment really is. I'm told the government will be delivering its federal budget next week on Tuesday, February the 27th. That might be a litmus test to see whether the deeds do actually match the words, domestically as well as globally. Now, as has been said, this series is the first that the Lancet and maybe any other medical journal has dedicated to Canada. And it lays out some remarkable opportunities for this nation, renewing the tripartite social contract for universal health coverage, sharpening Canada's role in global health. But none of this would have been possible without some fantastic writers and authors of our series, and I do want to, before they speak, pay tribute to their tremendous work. I would like to pay tribute to our partners, the Aga Khan Foundation, Global Affairs Canada, and the University of Toronto. And particularly, I would like to thank my wonderful colleague, Jocelyn Clark, who's sitting on the front row here. Jocelyn is a Canadian, as you've heard. Well done, Jocelyn. She has been with the Lancet just 2 years, but in that short space of time has brought energy, commitment, creativity to our work in the most remarkable way. And without Jocelyn's passion and love for this country and belief in what it has achieved and can do still further in its achievements, we would not be here today. Thank you, Jocelyn. I'm exceedingly grateful to you. And now I hand over to you for your few words. Thank you.
Oh my gosh, always difficult to follow Richard Horton at the podium. But with those kind words, I've gone completely red, Canada red, I'm sure you can tell. So thank you very much, all of our opening speakers. And thank you to our partners and all the individuals who helped make this happen, this wonderful gathering of people in this extraordinary space, which has really helped make this launch happen and allowed us to celebrate and share the Lancet's first ever series on Canada. You've also given us an extraordinarily warm welcome here to Ottawa. Thank you for not welcoming us with a snowstorm, and which I think might be on its way. Yeah. Okay. Yeah. Touch wood. But I have to tell you, Richard Horton has been in Ottawa for less than 24 hours, and I have a sense that he's thinking about exchanging his British passport for a Canadian one, judging by how wonderful our engagements have been with some of you already. And of course, we have a very liberal immigration policy, so he's probably got a good chance. So, of course, as a proud Canadian and editor at The Lancet, how these two things come together for me makes this a very special joy. This series was an enormous amount of hard work. I think probably for the authors, much more work than they ever expected. So I for sure have to thank them first for sticking with us. Once we got the idea, the only person to go to was Peter Tugwell at the University of Ottawa. So I want to, in particular, thank him. We first approached him with the idea, and he and I together found the incomparable Danielle Martin, Stephanie Nixon, and Kelly Lee, who came on board to lead these two papers. And they, in turn, assembled an incredibly rich and expert author team that reflects Canada's vast diversity. And that's not easy to do. So we're very, very grateful to them. The two main papers, as you've heard, trace the legacy of the country's health system and its global health role. They offer lessons for other nations, but they very much highlight the challenges and the demands ahead. We'll look forward to the panel discussions that will happen shortly to discuss those two main papers. We then commissioned accompanying commentaries, one from Margot Greenwood and her colleagues at the National Collaborating Centre in Aboriginal Health at UNBC, one from Tim Evans at the World Bank, one from Minister Jane Philpott, whom I'll introduce in a moment, on Canada's efforts to ensure Indigenous health and well-being, and one from our Prime Minister Justin Trudeau laying out Canada's vision for global health and gender equality. We commissioned this series because Canada is important in the world for health. We know that debating healthcare in Canada is a national pastime. But what we wanted to do was shine our international spotlight and contribute to wider debates about Canada's leadership, which is needed more than ever. And I can assure you we're not going to go away. This spotlight will continue to shine on this country as it moves forward on health. The main message is that we have a long history of accomplishment that Canadians should be proud of, but that we mustn't rest on our laurels. We need more strategic leadership at home and abroad. It needs to be bolder, more responsible, more action-oriented, and inevitably it's going to need more financial investment. But the other clear message is that we cannot advance by leaving the Indigenous peoples in Canada further behind. So we look forward to the session today and very much look forward to your feedback and engagement on this series. So now it's my real privilege and pleasure to introduce Minister Philpott, who will give our keynote remarks. Before I do that, I just want to take a moment to recognize and thank another remarkable Canadian woman, who's Monique Bejin, and was intending to be here today, and I know she was very excited to be here, but unfortunately yesterday afternoon she fell ill, and she's experiencing some very severe knee pain. But I got a really lovely message from her yesterday afternoon, and she sends her best wishes to all of us, including you, Minister Philpott. And she has given us so much support and enthusiasm for this series, so we'll miss her. For Canadians, we know Monique Bejin as our trailblazing former Canadian Federal Minister of Health in the 70s and 80s, during the time that the Canada Health Act was legislated, giving birth to our healthcare system. She is simply a national icon, but she's also a model of leadership. She's feisty, she's funny, she is a feminist, and now I can call her my friend because of this series. So I'm really, as you all are, indebted to her for her support and her leadership. For those of you who don't know Monique, we do profile her as part of this series, along with two other remarkable pieces of work that you can find online. One is a beautiful profile of Cindy Blackstock, who's a tireless advocate for First Nations children. And then we have a stunning photo essay of Indigenous healthcare workers in northern BC. So Minister Philpott, I didn't know the minister before this morning when I met her, but I feel like I know her. And that's because even though I live abroad, I check the Canadian news every day. And it seems to me nobody is in the news more than this woman. And she's often asked very tough questions. But it's clear she answers them with an incredible amount of poise and intelligence and passion. So we are so thankful and fortunate that you are here today to speak to us. Jane Philpott had a distinguished medical and international health career before she entered politics in 2015. She was Canada's Minister of Health until last year when she took on the new portfolio of the Ministry of Indigenous Services, a most critical and challenging file. As you've heard, she's also a physician, so we know that she's reading the Lancet every Friday morning. It's not lost on us at the Lancet the depth of importance of Indigenous people's health, rights, and equity in this country. And it's not lost on us the critical importance of advancing reconciliation and progress on health, working with Indigenous communities in this country to make that happen. If anybody can make that happen, it will be this woman, Minister Jane Philpott. So without further ado, please join me in welcoming with great thanks the Honourable Minister, Dr. Jane Philpott.
Thank you very much, Jocelyn, for that exceedingly generous welcome. And it's such a delight to be here with all of you this morning. I want to thank our hosts, the Aga Khan Foundation, for your generosity to us today as well, and of course the University of Toronto for also supporting the gathering and the launch today. Like others before me, I want to acknowledge that we are gathered here on unceded Algonquin territory, and I want to thank the Algonquin people for letting us gather in this beautiful place on this land and for the way that they have cared for this land over many, many years. Je suis très content d'être ici, dans cet endroit qui est si merveilleux, et c'est un grand plaisir d'être avec vous. Merci pour votre présence ici pour cette occasion qui est si spéciale pour nous, les Canadiens et Canadiennes. We're really honored that the Lancet chose to do this, to dedicate an entire issue to Canada's health system and Canada's role in global health. In fact, I did start reading The Lancet a very, very long time ago when I was a medical student in the 1980s, and I think I can still remember some specific issues. I remember issues where we first started learning about acquired immune deficiency syndrome and the role that The Lancet played in some of the early research associated with that. And yes, Jocelyn, it still arrives in my inbox every Friday morning. I can't say that I always follow the links and get a chance to read the articles, but I'm still receiving it. So I'd have never dreamed back when I was a medical student that I would have this incredible privilege to be here today to celebrate this landmark series. I want to also acknowledge many of my colleagues in Cabinet who would love to have been here today but weren't able to join us. I think of the Minister of Health, Jeanette Petitpas-Taylor, who would want to be here celebrating today. Also, Marie-Claude Bibeau, who is our Minister of International Development and La Francophonie. And also, of course, the incredible Carolyn Bennett, who is our Minister of Crown Indigenous Relations and Northern Affairs. All three women champions of Canada's healthcare system and Canada's role in global health. We're all so proud that our Prime Minister has contributed such an incredible commentary to the Lancet series, where he elaborates on our vision for global health and focuses specifically on this important issue of gender equity. And as you have, if you haven't already had the opportunity to read the article, you'll note the Prime Minister's decision around focusing our G7 Leaders Summit that's going to be hosted by Canada in just a few months on gender equity at the top of the agenda. Canada has a plan to devote 95% of our international assistance to initiatives that specifically target or integrate gender equity and the empowerment of women and girls. And as the Minister of International Development has said, focusing Canada's international assistance on the full empowerment of women and girls is the most effective way for our international assistance to make a difference in the world. And as someone who's worked for many years in countries like La République du Niger, en Afrique de l'Ouest, I can definitely attest to the incredible power that we will see in transforming nations when there is a focus on gender equity. In June of 2016, we launched Canada's Feminist International Assistance Policy, and the Prime Minister has called this the first explicitly feminist international assistance policy in Canadian history. To that end, our government is investing $650 million to address gaps in sexual and reproductive health and rights. And I'm proud this morning, before I get away from the topic of gender and feminism, to look across the front bench here and to see colleagues like Stephanie and Danielle and Jocelyn and Lynn, my U of T colleagues, and to see women leading the way, and then to think about people like Margot and Nadine, who are also major contributors, and I could point to many, many others of you in the room, but we walk the talk around the role of women in leadership in health and equity in this country. Canada is also taking a leadership role to end epidemics that disproportionately affect women and girls, including HIV/AIDS, tuberculosis, and malaria. And in September 2016, most of you will know that we hosted the 5th replenishment conference of the Global Fund to fight AIDS, TB, and malaria. And world leaders responded to Canada's call and were able to raise nearly $13 billion US in pledges, including Canada's contribution of $804 million. A future free of HIV, AIDS, tuberculosis, and malaria is closer than ever. But we can't celebrate our international progress without recognizing the tremendous amount of work that we have to do here in Canada. And the Prime Minister notes that in his commentary, where he says that we must address historic injustices and inequalities on our own doorstep if we wish to champion these on the world stage. And so to illustrate some of these challenges that we face within our borders, I want to go to a story, the story of a young girl named Eileen. Eileen is from a small community called Qikiqtarjuaq. It is in Nunavut. It's over 2,500 kilometers north of here in a community on Baffin Bay. And just over a year ago, Eileen, who is the girl from this community, died here in Ottawa in a hospital. She was 15 years old. Eileen had experienced symptoms for more than 2 years, and she spent the last 2 weeks of her life in an intensive care unit in this city. But tragically, it was only a few hours before her death that she received a correct diagnosis. She had tuberculosis. So in Ottawa, in 2017, a 15-year-old girl died of tuberculosis, a preventable, treatable bacterial infection. But her story is, of course, not just the story of an infectious disease. It's the story of nursing shortages, language barriers, weather delays in medical transportation from remote communities, and an epidemic that has persisted among Inuit in Canada for more than a century. Eileen's story illustrates a truth that is known to most of you. Improving health outcomes requires more than biomedicine. It requires an intentional focus on the social determinants of health. We will not achieve our goal of eliminating tuberculosis in the Inuit homelands unless we deal with issues like housing, recognizing that rates of overcrowding are as high as 52% among Inuit population in Canada. In Canada today, there are 1.7 million First Nations, Inuit, and Métis. And when compared with non-Indigenous Canadians, life expectancy is as much as 11 years shorter for Inuit. Infant mortality rates are 2 to 3 times higher than non-Indigenous Canadians for First Nations and Inuit. The prevalence of diabetes among First Nations on reserve is almost 4 times higher, and in some cases more than that. The prevalence of tuberculosis among Inuit is a stunning 270 times higher than it is for the Canadian-born non-Indigenous population. Addressing that endless list of health inequities requires more than better health care. It requires better housing, education, roads, and so much more. But in my role as Minister of Indigenous Services, I need to dig even deeper. Yes, beyond biomedicine, but even beyond the social determinants of health. How did we get to a place where Indigenous peoples do not generally enjoy the same health outcomes as non-Indigenous Canadians? I believe that one of the most succinct descriptions of how these appalling gaps have developed can be found in one of the calls to action of the Truth and Reconciliation Commission. Call to action number 18 reads as follows. We call upon the federal, provincial, territorial, and Aboriginal governments to acknowledge that the current state of Aboriginal health in Canada is a direct result of previous Canadian government policies, including residential schools, and to recognize and implement the healthcare rights of Aboriginal people as identified in international law, constitutional law, and under the treaties. So that's the real story. And I like to read that call to action, number 18, as a bit of a medical assessment. because it has right there the cause, the etiology, as well as the treatment plan. What's the cause? What's the etiology of how we got here? It says that health outcome gaps are a direct result of previous Canadian government policies. And what's the treatment plan? Well, it says that closing those gaps requires the recognition and implementation of rights. The deplorable health outcome statistics have their roots in laws, policies, and operational practices of our country. For generations, First Nations, Inuit, and Métis were denied rights, denied the right to self-determination, and subjected to laws, policies, and practices based on domination and assimilation. One of the most egregious policies was the residential school system, which began in 1876 and persisted for more than a century. With the explicit goal of assimilation under the dominant Canadian culture, roughly 150,000 Indigenous children, some as young as 5, were separated from their parents, punished for speaking their own language, and subjected to abuse, inadequate housing, and insufficient nutrition. The effects on individuals, families, and communities from this form of cultural genocide will be felt for generations. Let me tell you another story that speaks to the trauma resulting from the residential school system. Jerry is a 25-year-old Métis youth. He was in foster care from the age of 8 to 14, during which time he lived in almost 40 different homes. His mother couldn't take care of him because of her mental health issues related to residential schools. Jerry's grandparents wanted to take him in, but lacked the financial means to do so. Jerry spoke about a month ago at an emergency meeting on First Nations, Métis, and Inuit Child and Family Services that we hosted here in Ottawa. He said that day, "Foster homes strip you of your identity when you walk in. They see us as numbers, not people. You get lost. You slowly lose everything that made you." Jerry suffered from dyslexia and ADHD. He said that foster parents have high expectations of behavior, and many couldn't deal with my needs. Jerry left the system at age 14 and got a job. He did manage to connect eventually with his Métis family, but he says that he hasn't made the same connection with his grandpa as he had when he was a child, because that relationship is gone, and the support that he really needed was from a mom. Jerry's story is one of intergenerational trauma, poverty, and disconnection from his culture. But it's also a story of a people who had been denied control over their own lives. The denial of the rights of Indigenous peoples is directly linked to the glaring socioeconomic gaps that we experience in Canada, as well as poor health outcomes. And in September of last year, the Prime Minister stood before the United Nations General Assembly and acknowledged that the failure of successive Canadian governments to respect the rights of Indigenous peoples in Canada is our great shame. Last week in the House of Commons, Prime Minister Trudeau announced that our government will develop, in full partnership with First Nations, Inuit, and Métis, a recognition and implementation of rights framework. It was an historic moment with historic words. However, as one First Nations elder reminded me at a meeting some months ago, words do not feed a table. His point was to demand action, including the resources to accomplish ambitious goals. And so we need to respond to that matter first. Canada has designated to date in the last 2 federal budgets close to $12 billion to improve social determinants of health for Indigenous peoples, including funding for housing, clean water, and equitable funding for education. The progress achieved since 2015 by working together with Indigenous partners is significant. Direct investments for health include quadrupling the number of mental wellness teams across the country, approving more than 33,000 requests for care under a program called Jordan's Principle, expanding our prenatal escort policy, creating an Inuit Crown task force on the elimination of tuberculosis, and more. But I am convinced that we will not definitively address health outcomes nor the broad socioeconomic gaps between Indigenous and non-Indigenous Canadians without the recognition and implementation of inherent Indigenous and treaty rights. Permit me to read from Articles 3 and 4 of the United Nations Declaration on the Rights of Indigenous Peoples, which says, Indigenous peoples have the right to self-determination. By virtue of that right, they freely pursue their economic, social, and cultural development. Indigenous peoples, in exercising their right to self-determination, have the right to autonomy in matters relating to their internal and local affairs, as well as ways and means for financing their autonomous functions. Self-determination, autonomy, the free pursuit of economic, social, and cultural development. These are the most fundamental determinants of health and wellness. Yes, we need health workers. We need technology and medicines. We need housing and jobs and education. But most of all, Indigenous peoples need what was prescribed for them in the Royal Commission on Aboriginal Peoples more than 20 years ago. And it lists 3 things. Number 1, they need control over their lives. Number 2, they need land, resources, and self-chosen governments with which to reconstruct social, economic, and political order. And number 3, they need time, space, and respect from Canada to heal their spirits and revitalize their cultures. Behind us is a path marred by the denial of the inherent and treaty rights of Indigenous peoples. The path ahead requires the recognition and implementation of those rights. I'll close with a final story from a recent visit with the Prime Minister to Pekanjikam in Northern Ontario. We met that morning with the Chief and Council, and as we sat there, the Chief pointed down the table to a woman councillor and described the fact that she lives in a 2-bedroom house with more than 20 other family members. He described how she and her family are required to sleep in shifts, and that because of the fact that they have to shift through the night so everyone will get time in a bed, one young person recently had to drop out of high school because he was exhausted. The boy couldn't study because he couldn't get a decent night's sleep. This is happening in Canada, in this affluent province, in this affluent country today. We must do better. The United Nations Declaration on the Rights of Indigenous Peoples affirms that the recognition of rights is not only the foundation for better health outcomes, it is the prerequisite for the survival, dignity, and well-being of Indigenous peoples. This is the approach with which our government will go forward with Indigenous partners, so that Inuit girls from Nunavut will not die of tuberculosis, so that Métis boys are not sent to foster care because of intergenerational trauma and poverty, so that First Nations children do not have to drop out of school because they can't get enough sleep in a crowded home. Improving health outcomes for Indigenous peoples is a social and economic imperative for Canada. More importantly, it is a moral imperative. And I assure you today of our government's unwavering commitment, grounded in the recognition and implementation of Indigenous rights, to the pursuit of justice and health for all. Merci beaucoup. Chimegwech.
Thank you very much, Minister Philpott, for your beautifully engaging and hopeful speech. We really, really appreciate you taking the time out of your schedule to be with us here today. So we will move on now to our panel discussions. So if I could ask the authors of the first paper to plan to come up. And I'll hand the baton over to Andre Picard. Speaking of national treasures, probably doesn't even need an introduction, but he is an award-winning and probably Canada's foremost health reporter and columnist, and usually the voice of reason on most matters of health in Canada. So we're absolutely delighted he was able to come from Montreal to join us. So I'll hand the baton to you for the two panel discussions. Thanks.
Thank you. Merci beaucoup, Jocelyn, pour votre gentillesse. Welcome to our first panel, Canada's Universal Healthcare System Achieving Its Potential. The format is very simple. We're going to have two of the co-authors speak for 5 minutes each. Then we'll have a discussant, and then we'll have a moderated question and answer period with me. So without further ado, we want to spend our time talking about healthcare, so I'm going to give very brief introductions of our speakers. Our first speaker will be Dr. Danielle Martin. She's Vice President of Medical Affairs and Health System Solutions at Women's College Hospital and an Associate Professor at the University of Toronto. She's also the author of Better Now, 6 Big Ideas to Improve Healthcare for All Canadians. Danielle will be followed by Dr. Nadine Caron. She's a general and endocrine surgeon at Prince George Regional Hospital and a faculty member of UBC School of Medicine. Dr. Caron is also chair of the BC Medical Association's Committee on Aboriginal Health. And our discussant today will be Dr. Colleen Flood. She's a professor at the University of Ottawa and the inaugural director of the Ottawa Centre for Health, Law, Ethics and Policy. So here's to a good discussion. If you're tweeting, please use the hashtag Lancet Canada. And remember that you have all the articles we'll be discussing in print before you, and they're on Twitter. You can find them all on my Twitter feed if you're looking for them.
Thank you, Andre. Bonjour, good morning, and thank you to the Aga Khan Foundation and the University of Toronto for hosting us, to Richard Horton, Jocelyn Clark, and the team at the Lancet for their extraordinary leadership of this series, Minister Philpott and Prime Minister Trudeau for their support of this tremendous Lancet series on Canada, and most of all, I want to begin by acknowledging our extraordinary team of authors for this first paper in the series. All of the authors for this first paper are present here with us today. From east to west, Ashley Miller from Dalhousie, Amélie Kennel-Vallée from McGill, Bilkis Visanjé from Université de Montréal, Greg Marshallden from the University of Toronto and the University of Saskatchewan, and Nadine Caron from UBC. And all of the authors will be participating in the discussion and the Q&A following these brief presentations. Canada is a complex project. 36 million people from a rich diversity of backgrounds living on this vast geographic expanse of land, along, of course, the longest shared border in the world with a country whose health system defies international comprehension, yet sets the tone for so many of our public debates. Notre système de santé est fondé sur un contrat social entre les gouvernements, les praticiens et la société. Un contrat qui requiert un ferme consensus autour des principes d'équité et de solidarité sociale. To Canadians, the notion that access to healthcare should be based on need, not ability to pay, is an unquestionable defining national value. Our system is built on an implicit social contract between governments, healthcare providers, and the public, a contract that demands a shared and ongoing commitment to equity and solidarity. But we should not romanticize it. Our system is far from perfect, and the first paper in the Lancet series on Canada provides an overview of the history of Canadian Medicare and identifies some key challenges that we argue must be addressed if it is to be worthy of such immense national pride. In the paper, we describe the narrow but deep coverage of Canada's universal system, one in which doctors and hospitals have been dominant for more than 50 years. We outline the global forces shaping the present that will be easily recognized by international readers of The Lancet, forces such as the demographic shift occurring as our population ages, fiscal constraints in a time of less robust economic growth, and the rising need to address the social determinants of health if we are meaningfully address the health of populations. But in addition, we point to some challenges that are uniquely Canadian, a special snowflake, of course, that we are as a country. Early in our work, one of our team members commented in passing that to understand how difficult it is to deliver healthcare services in Canada, one need only look at a map. And I was frappé, as they say, by that comment, and so we have provided two maps with this paper. The first illustrates the geographic concentration of Canada's population and of its hospital services, painting a picture of why rural and northern communities are so often ill-served in this country. The challenge and expense of delivering services north of that densely inhabited Canada-USA border corridor, the need for remote primary care services and frequent medical transport to specialized centres will, I think, be a surprise to many international readers of The Lancet. Canadians living in remote areas must often travel long distances to access anything beyond the most basic forms of health care. For example, in Nunavut, 58% of patients needing hospital care are transported outside the territory to get it. A second map illustrates the tremendous ethnocultural diversity of our country, where more than 1 in 5 people today was born elsewhere, and where we continue to have very high rates of migration. This diversity, of course, is a tremendous source of economic and social resilience, and it requires the design of healthcare services that will meet the particular and legitimate needs of different migrant groups. In light of these global and Canadian trends, our team has identified what we believe to be the 3 crucial issues to be addressed in this generation. These will be familiar to the Canadians in the room: long waits for non-urgent specialty care, unacceptable disparities in health outcomes for Indigenous Canadians, and inequitable access to services outside the traditional Medicare basket, particularly prescription drugs. These challenges call for bold action of the kind that has not been taken in Canadian healthcare in our generation. And my colleague, Dr. Nadine Caron, will speak to the call for change that we thus put forward in this series.
Thank you, Dr. Martin. I'd like to thank the Algonquin Anishinaabe people for sharing their beautiful, beautiful traditional and unceded territory with us today and every day. Thank you to Minister Philpott for your wisdom, your courage, your leadership, and your insightful words that rung true to me as an Indigenous Canadian, and I'm sure everyone in this room. As a team, we have calls for change based on research, dialogue, and the contemplation that went into this manuscript. In proposing a renewal for the tripartite social contract embedded in the healthcare system that we call Canadian, there are roles for government, for healthcare providers, and today I'll focus on physicians, and the Canadian public. Starting with the roles for government. True change to create a healthcare system for tomorrow requires a bold, proactive commitment to move from the incremental improvements or the management of the status quo to ensure a vital, sustainable healthcare system that matches the needs for all Canadians. In an era in which Canada is reasserting its commitment to progressive values on the international stage, healthcare represents a key domestic opportunity to recommit to the core Canadian values of equity and solidarity. Intrinsic to this is the expansion of services to be publicly funded. It is clearly evident to us that the Medicare basket now include universal coverage for prescription drugs, expanded home care, long-term care, and mental health services. Constructive partnerships between all governments and our Indigenous Canadians is required. Not helpful, not insightful, not generous inclusion, required in order to overcome the egregious health disparities endured by First Nations, Inuit, and Métis peoples. We need to focus on healing from the intergenerational trauma and adopt a strength and wellness-based approach when addressing both the gaps in health status and in the social determinants of health between Indigenous Canadians and non-Indigenous Canadians. The unprecedented Truth and Reconciliation Commission's report shared the gut-wrenching and courageous stories of Indian residential school survivors who lost connection to family, land, culture, language, through a process of intended assimilation into Western society. The report's calls to action address crucial themes, improving and the holistic view of health, highlighting the social determinants of health as non-negotiable elements that must be addressed. All levels of government are responsible to heed this responsibility. Many themes in the TRC are rooted in self-governance. The launch of the new Federal Department of Indigenous Services must be open to the renewed terms of engagement with Indigenous governments, leaders, and communities. There is the need to support new models of self-governance and self-determination within the healthcare system and beyond. Regarding our recommendations to healthcare providers, we need physician engagement, both at the individual and at the collective level, to address these long wait times. Solutions often involve reorganization of the traditional referral models and the introduction of team-based interdisciplinary care and expanded scopes of practice. Canadian physicians are well situated to constructively contribute to such efforts, to divine value, and to help shift behavior. As founders of evidence-based medicine, as vital contributors to global health research, Canadian physicians must help to lead the necessary debates and research on change within healthcare systems. The Canadian public plays a critical role. There is a need to engage patients in system stewardship through campaigns such as Choosing Wisely Canada, which offers 4 simple questions that patients can ask a provider to start the conversation about whether a treatment or a prescription is needed. Public input should be nurtured, as it can help policymakers actually balance the need for healthcare improvement and investment with other social priorities. This places the value of the public input and a role beyond simply end users, as we believe all Canadian citizens and those who dream to be Canadian citizens in the future would be willing to step up and accept this responsibility. There are global lessons. Canadian experience is a cautionary tale of incrementalism. Without bold political vision and courage, progress on wait lists, on a coverage expansion, and indeed on Indigenous health is too slow, it's too difficult to achieve. Clear mechanisms are lacking to consistently realign resources to meet the population's needs, promote evidence-based care, reduce variation, and contain costs. We need strong political leadership to achieve Tommy Douglas's dreams of that second reform, to focus on population health needs with an emphasis on reforming the delivery models and, of course, on the social determinants of health. We need to achieve a truly universal healthcare system, and to do so, we need to do it without relying on incremental change. Determined action with a joint effort with government, with the public, and healthcare providers is necessary to achieve this healthcare reform. With this vision and this renewed commitment, this ambitious goal, we believe, is truly, truly possible. Chimigwich, thank you, merci.
Good morning. Bonjour à tous. I want to also acknowledge that we're here in Algonquin territory, and it's my privilege to be here. So thank you to everyone, and thank you particularly to Jocelyn and the Lancet for inviting me to be a commentator today. It's a fantastic paper that you guys have written, and I want to thank you for that and your leadership on these issues in general, Danielle in particular, for the country. So thank you for that. I immigrated to Canada, as you can tell by this melodious accent, about 20 years ago, and I fell in love with Canada after a paddle through Algonquin Park, because of its great universities and its embrace of immigrants like me, but most of all because of Medicare. So 20 years ago when I came here, an old family friend of mine from New Zealand had been living in pain for well over 2 years at that point, waiting for a hip operation. And so I found, coming to Canada, to find out that at that time there weren't those waits. And there wasn't a two-tier system so that you didn't, people without insurance were treated the same as others. I thought that was revolutionary. But over the course of the last 20 years since I've been here, the jewel of Medicare has diminished. It's diminished, as the authors point out, because our healthcare needs have changed and the focus on one type of provider, that is physicians, and one type of place of provision, that is hospitals, has been eclipsed by shift to new technologies and kinds of care and communities and by different kinds of providers. The jewel of Medicare has diminished as well because of our failure to truly wrestle with wait times, which I believe has caused Canadians to lose faith in public Medicare. Martin and her colleagues, Danielle and her colleagues, argue for a new deal in healthcare, for strong leadership by government, for a greater role for physicians and other healthcare providers, and for a recommitment by us all to the principles of Medicare. But I was left at the end of it wondering, but how do we operationalize that? How do we actually do that? And do we just have to wait for the odd Jane Philpott to come along and hope that she somehow single-handedly achieves that? I don't think that's good enough in the long run. I think we need to systematize this, and the word that they used a few times throughout the paper is the word of accountability, and that's the word I want to pick up on in my comments. I think that the word accountability, the implementation of accountability is what is, I see, the key feature of all high-performing healthcare systems. And it is on that particular characteristic that Canada has fallen behind in some ways. And I know you're probably going to say, oh my goodness, accountability, everyone talks about that, you must be a lawyer. And it's true that accountability is frequently hijacked by many, hollowed out to be a meaningless bean-counting kind of a tidbit, and sadly great ideas are frequently so hijacked. But nevertheless, I think a lack of accountability is what not only Canada, but other healthcare systems in the world are failing on, and why we are falling behind, not only in Canada, but globally in healthcare. And our systems are failing because of that lack of accountability. We spend a great deal of money. We talked about new money. Not so much for me, because we spend so much for very marginal returns to health. And we can do infinitely more with the resources that we invest in our public and private healthcare systems. I bring you Exhibit A. This is my antihistamine drug, cetirizine, which is a generic. The other day I got a bit of a shock when I went into Philpott, moving to the Ottawa Valley. Believe me, people, it almost killed me. That I had to pay a $22 copay. I have insurance through my my university plan. I said, my goodness, what is the cost of this generic drug? $88 for 90 tablets. I checked on the New Zealand website. New Zealand has a universal drug insurance plan. It covers everybody, very small co-payments at point of service. This exact same drug is $2.02 in New Zealand, plus a $6 dispensing fee. The total price is $8.88 for the 100 pills. This is 90 pills. This is $88. So we're talking 10 times the price. Now, basic economics is that if we paid the same price for this bottle of pills in Canada as we do in New Zealand, you could cover 10 times as many people. And how do they do that? They do that through the government taking it very seriously, because they have to pay for the costs of everybody. Everybody's in, and they use competitive tendering, so the drug company gets a pretty good deal because they get the whole of the New Zealand market in exchange for a good price. That's what accountability does. When you're accountable for a whole population, for the cost of that care, and for return on investments. Now, some of you will say, well, hey, but I can get some other crazy, antihistamine here. It's really great. You can still do that in New Zealand. You can buy that if you want to, but do it with your own money on top of. There's nothing to limit that. Go crazy. So the problem is, I think, a problem of democracy. When we vote our governments in and out of office from time to time, that's wholly insufficient to ensure the layers of accountability that we need throughout the whole healthcare system. And Bill Gates has written, you can achieve incredible progress if you set a clear goal and find a measure that will drive progress towards that goal. It's pretty basic. And as health systems fail to deliver accountability in the internal governance structures, citizens around the world are increasingly turning to the courts to serve this function. This is where my students come in, people like me. And legal systems around the world are taking on this task with growing enthusiasm, delivering accountability, though, on a very selective basis. Those of us who study this have found this trend to be both baffling, erratic, and unpredictable, delivering progressive results in some countries and regressive results in others. And so while there might be different opinion on the role of judicial review as an option for last resort for achieving an accountability in health systems, I don't think anybody, in my opinion, would defend courts as an option of first resort for ensuring accountability. They're just too messy, too costly, too unfair, and too generalised a forum for the job that needs to be done. And I know that this concept of accountability pales in sex appeal probably next to flavour of the week ideas like big data or artificial intelligence or digital health. But we already have a lot of data, as the authors point out, about what works and what doesn't work, but we don't act upon it. So the challenge is how to galvanise all of these powerful people that make up our health system to act upon the data to make the changes that we need. Now, there's no magic bullet how to weave the steel wire of accountability throughout health systems and across the public and private divide. It's a task that requires continual evolution, creative thinking and institutional design, and responding to changing technologies, providers, culture, and needs. It requires an understanding that measurement is a continually evolving process, and there may be very important dimensions of healthcare systems that we haven't quite figured out how to measure. Achieving accountability will always and ever be a work in progress, but one that we must relentlessly strive towards. I think accountability starts with the overarching legal and governance frameworks. So I noticed in your paper that sort of the history of Medicare sort of seems to stop in 1984 with the Canada Health Act. I think that's interesting, and I think that revisiting the Canada Health Act before the courts do it for us, the framework of provincial health insurance legislation, the framework of funding by governments of various agencies and different providers, hospitals, physicians, pharmacists, and so on. This is what is needed at this point, to make sure that accountability is embedded throughout all of these legal and governance structures. We need a clear, strong articulation in our laws that governments are there to act for Canadians and not at the convenience of physicians, with all due respect, providers, the industry. Governments are not there for them. They should be there for Canadians. To hold all of those in receipt of hard-won and limited tax dollars to account for what they will do with that, to steadily improve Medicare. And I believe that governments should be responsible for all of our health objectives, not just hospital and physician services, but that we acknowledge too that resources are limited. But with those limited dollars, that we must do the very best we can, not only for Canada, but for the world. Thanks very much.
Great. So thank you, everyone. A really rich paper, lots of stuff in there. I was saying to you, Danielle, earlier, I think you covered everything. I don't know what to critique. But we don't have a lot of time for questions, so I just want to do a few quick ones before we get on to the next panel. I want to start, I was struck by something in the paper. You say that Canada's health system is not in crisis, but it's in stasis. So how do we move beyond that, this stuck in the mud for 40 years? Where do we start?
Well, others on the team may wish to comment. I mean, that was in fact an oblique reference to something that David Naylor said many times after he, you know, the not this past Naylor report, but the Naylor report before it on innovation. And I do think it is sort of a situation that we find in the Canadian health system that, you know, we have been kind of making do with what we've got for a very long time. And so the question is, how do you kind of create that push? So I'm wondering, Greg Marshallton, to put you on the spot as someone who has you know, tremendous depth of understanding of the history of Medicare, if you want to comment on this crisis versus stasis component.
We're just going to bring you a mic, Greg, because there's some people online. Yeah.
Poor Greg has a cold, but he's smart with it too. So
that's on.
That's right, and thank you for putting me on the spot like that. Wow. Well, first of all, many years ago I was involved in a little enterprise called the Commission on the Future of Healthcare in Canada, and we recommended actually opening up the Canada Health Act and and really adding accountability as the sixth principle. So part of that is the accountability equation. But the other part of it is, I think, the kind of federal, provincial direction setting by leaders in both the federal government and at least some provincial governments with some vision as to where they want the system to go. The stasis is, should we proceed with expanding universal coverage, or should we move backwards? And it's never expressed as moving backwards. It's always expressed as, in a sense, modernizing the system. But that's what it means. And that basic directional decision has not been made. And then finally, I think that there is an enormous benefit from a decentralized federation, in the sense that you can have a fair amount of experimentation at the provincial level. And we, in fact, are undergoing that. But the knowledge of those experiments are not disseminated across the country. We have no platform or vehicle for that. And it's desperately needed. And I think that that kind of knowledge dissemination would, in fact, change things quite dramatically. But there has to be that push to do things that are going to be much bolder than what we've done in the last 40 years.
Great, thank you. So, Dr. Caron, you identify in the paper 3 policy issues that are pressing. So, wait times, inequitable access to services beyond hospitals and doctors, and Indigenous health disparities. I think we probably all agree in this room the third one is the most important. So I want to ask you about that one. We've got a massive number of a dizzying array of services for First Nations, Inuit, Métis people, but they don't seem to be working. How do we make it work? And we only have 10 or 15 hours.
Yeah. Well, first of all, I want to thank you for recognizing that you think that it's the most important. And I think one of the reasons why it's the most important is because Indigenous people also need or care about the wait times. Indigenous people also need an expansion of services and the accessibility. And so there is overlap, and it's not separate. It's just that it's this group of individuals and populations, communities in Canada that have egregious disparities in health status and in access to health care. It's not working. And I think it's not working because we can see those disparities. It's interesting because we always talk about closing the gap, and we're doing that. So it's not like it's for lack of trying. And I think especially with our current government, I can say that my 9-year-old daughter broke into tears when Prime Minister Trudeau was elected because of his commitment to First Nations health. I think that's an example of the leadership that this country has right now, and it's just a perfect timing. But I think what we need to do is recognize that self-governance needs to be in there, self-determination needs to be in there. I think anyone in this room would realize that when you are wondering what is best for you, what's best for your family, what's best for your community or your people, that you have an inherent understanding of that. And in terms of even priorities, you can't fix everything immediately all at one time. But you can prioritize things, and I think that's what we're actually getting a chance to do in British Columbia with the First Nations Health Authority. It's the decentralization. It's something that we're doing in British Columbia that's not happening anywhere else in Canada, and we're getting an opportunity to look at really community-driven priorities, where the First Nations Health Authority, although they have the oversight and the jurisdiction to actually look at this, they are listening to their communities in terms of what's important. But it does have to be done under the umbrella of Indigenous people. We're First Peoples, but we're also Canadians. And you cannot separate one from the other. I don't want that. My colleagues don't want that. My family doesn't want that. And I think moving forward, improving Medicare, looking at the Canada Health Act, looking at what our publication has put forward, and recognizing that Indigenous Canadians are going to benefit from all of that, with the issues that are going to fall with Minister Philpott in terms of bringing in the self-determination and the self-governance.
So as the minister said, get those tools of colonialism designed to hurt people, get them out of the way.
I think you're absolutely right in terms of the TRC. That number, it's looking at the etiology, so fix the etiology by addressing it and making sure that what happened is actually amended. And it doesn't mean just not doing it anymore, it means fixing the problems that it caused.
So, Professor Flood, I heard in the paper I saw, and I heard from you that we have our principles right, we have our values right, but it's not working. So, is it fixable?
Oh, of course. Absolutely fixable. I think, you know, the idea that expansion is ridiculously expensive, we can't possibly afford it. I hope my example, my own personal example, proves that that is not the case. And that we can learn a lot from other colleagues. We have some colleagues here from the Netherlands, for example, from other jurisdictions that have much broader range of services inside of the basket of care that is provided. And, you know, they haven't had to pack up shop, close Netherlands up and shut it down because of cost overruns. So other countries are able to achieve this. I think we can achieve this within our value framework. It doesn't, you know, again, in New Zealand, the co-payments are very small. It doesn't mean you have to introduce two-tier healthcare for physician services, as some people argue. One does not necessarily mean the other. So this is all eminently doable. And I think it can be respectful of federal and provincial jurisdictions to allow the provinces and First Nations governments to pick the processes by which they decide what is within their basket of services. I think that's what the federal government should be saying. We want you to go big, and but you have to have a just and fair process for determining what is within the basket. And that would mean, for example, in my view, research from the Institute for Clinical Evaluative Studies in Ontario shows that about 800 people in Ontario alone who are diabetic die every year from want of access to medicines and like insulin. 800 people a year under the age of 65 in Ontario alone. This is bad. You know, I can get my bunion removed tomorrow. And it's not that bunions aren't important, but if I have to trade off one for the other, I know which one I'd pick. I think a just system would do that, and we're not there, but it is certainly within our ability to change that.
So we're almost out of time, so I like people to leave with some actionable stuff. So we have some powerful people in the audience. I want each of you to very briefly send them home with one thing that could be done tomorrow that'll make a difference. So Danielle?
So we talk in this paper about the notion of a tripartite social contract, you know, between governments, providers, and the public. And for sure, I think in the Canadian context, and Minister Philpott sort of alluded to this in her talk about democracy, we do not yet have well-developed ways for citizens to engage, you know, as Colleen was saying, other than voting governments in and out. How do you participate in the process as a citizen? But, you know, one of the things that was abundantly clear in the research that we did leading into this paper is that if there is one thing we need to do right now, it's this. We need universal pharmacare in terms of the reforms to Medicare. And that will only happen if public pressure is applied to decision makers. So what everyone can do today is go home and immediately call your member of parliament. and start to voice, the support that Canadians have for this principle, because I do think that level of democratic public engagement is going to be a critical input to a high-functioning health system for the future.
So we'll be watching the budget on Tuesday. We'll see.
Indeed.
Nadine?
Well, you know what, Danielle took the public. So we did have, it's a tripartite contract. So I will address the healthcare providers. So for healthcare providers in the room, or for those who are seeing their healthcare provider in the near future and or have access to one, knock on their door, or take time to contemplate what your role is in this. I focus on physicians today, and as a physician, I can see that point of view, but really making sure that you take responsibility for this. Right now, we can't change everything tomorrow, but I know what we can do is actually recognize that just because it's free, meaning that there's no transfer of any money at any one engagement at any time, that as a healthcare provider, you also are a steward of this and you're responsible for this. And so when you are using the healthcare system as a healthcare provider, because it's your job, to make sure that you take those resources and you treat them like gold, that you use them when you need them, you advocate for them when you have a patient, you fight for them when they're necessary, but you protect them, and you take the time to explain to patients and to your colleagues when you think that something is not needed, when you think that something else can be done first, and you take the time and the responsibility to use the healthcare system as a right and as a responsibility, not just one, but both of them. And I think, as we always forget, we're always looking at patients using and their expectations. I think we also have to look at healthcare providers. There's a responsibility there that we have to really take a handle on, and we could do that tomorrow. It won't take any time at all. You can do it tomorrow and for the rest of your career. And if you're not a healthcare provider, you can ask your healthcare provider and be part of that discussion.
Yeah, stewardship, a really essential concept for our health, from stewardship of the land through to stewardship of health dollars. Great. Colleen, final word?
Well, I have big visions of reforming law and that kind of thing. And
Tomorrow.
And so everyone's like, well, you're kind of crazy. But I believe that's the case. But I think more essentially what I see is that Canadians are too passive in their healthcare system. They're too, we compare ourselves, as mentioned in the paper, with the United States, and so we feel really good about ourselves in contrast, and I appreciate that and I understand that, and I think we actually don't give enough credit to ourselves for resisting those forces. I think that is another complicating factor in the Canadian milieu. But on the other hand, when we look at other countries and when we see gaps in access for Indigenous people, when we see gaps in access for diabetics, for the marginalised folks. I'm with my Comfy University health insurance plan. It's fine for me. But I think much more of us need to wake up to the gaps, the access, the problems, and start to kick the door in. Not just rely on having a brother-in-law who's a physician to make sure you can get in, but to kick the door in for everybody, because it's only when Canadians as a whole stand up and say, look, we want Medicare, we need Medicare, we don't want to pay top dollar through private insurance and private pay. We see how that goes in the United States. We want Medicare for all, and we want it much sooner than another 50 years, thanks very much. And I think it is doable.
So we have an expression in French, laisser sur leur faim, so leave people wanting for more. So I think we've done that today. We've touched on a few issues, and please read the fabulous paper, and please join me in thanking our panelists. I was going to go to the podium, but I'll just stay here. So we're going to go directly into our next panel. We're a bit time challenged. So our second panel is Canada's role in global health, supporting equity and global citizenship as a middle power. Same format as before, 2 speakers, 5 minutes each, then a discussant. So I'll introduce them. We'll start with Dr. Stephanie Nixon. You want to come first? Does it matter? Oh, Kelly. Okay, Kelly will go first. So I'll start with Dr. Kelly Lee, as she makes her way up, is a professor at the Faculty of Law at Faculty of Health Sciences at Simon Fraser University and the author of 13 books, including Globalization and Health, an Introduction. Dr. Stephanie Nixon is an associate professor at the Dalla Lana School of Public Health at the University of Toronto. She's also director of the International Centre for Disability and Rehabilitation and a longtime HIV/AIDS activist. And our discussant afterwards will be Robert Greenhill. He's the executive chairman of the Global Canada Initiative, and he's also served in many roles in the past, including president of CEDA, the Canadian International Development Agency. Yep, so Dr. Lee.
Thank you so much. I wanted to add our thanks to the Lancet, to the Aga Khan Foundation, the University of Toronto, and to the Algonquin people for allowing us to discuss this important issue today. I'm also acknowledging my co-author, Stephanie Nixon from the University of Toronto, Zolfi Buta from University of Toronto, James Blanchard from University of Manitoba, Slim Haddad from Laval University, Stephen Hoffman from York University, and Peter Tugwell from Ottawa University. So I'm absolutely delighted to be one of the co-lead authors on this paper with Stephanie Nixon, and this second paper of the Lancet series on Canada's role in global health. We also began, interestingly, by tracing Canada's past and contemporary history of colonization and nation building, which, as we've already heard from paper one, shaped the domestic health system. And correspondingly, nation building in a country of remarkable diversity and vast geography has also shaped Canada's role on the global stage. So the first part of our paper sets out Canada's political history and emergence as a middle power, a country of smaller size and more limited resources than great powers, particularly our southern neighbor. But in this middle power role, Canadians have carved out a respected niche as an honest broker of consensus building, diplomatic compromise, alliance forming with like-minded states, and a supporter of multilateralism. Canada's history and middle power capabilities, in turn, have nurtured a distinct approach to global health challenges. And the next part of our paper then describes this distinct approach, from the election of Brock Chisholm as WHO's first Director General, to recent funding patterns and how we have channeled these funds. And on funding, Canadian levels of ODA, Official Development Assistance, as a whole, could be described as good but could do better. We note that Canadian ODA as a proportion of GNP has consistently failed to reach agreed UN targets that we actually helped to set. And it still lags behind other middle powers, such as Sweden. On development assistance, specifically for health, Canada has done better in absolute and relative terms. Canadian DAH increased more than 7 times between 1997 and 2016, ranking third behind the UK and the United States among G7 countries. So what has Canadian funding supported? Well, it's difficult for us to summarize 60 years in 5,000 words that we were allowed. But first of all, some things do come through. Firstly, health equity has been a consistent theme and way of working for Canadians, highlighted by the work of the IDRC, the leadership that we've shown in major initiatives such as the Ottawa Charter, the Commission on Health Research in Development, and the WHO Commission on the Social Determinants of Health. So the pursuit of equity at home extended to the pursuit of equity globally. The second thing that came out from our analysis was that there are certain preferences in how Canada channels its development assistance for health, with multilateral initiatives and NGOs becoming more important. But like the domestic health system, there's a high degree of fragmentation, with our limited resources spread very thinly over a large number of funding bodies and initiatives. So in analyzing these trends, we noted the important contributions made by individual Canadians, from biomedical research to leadership in global health diplomacy. So panel one in our paper lists some of these individuals, but inevitably many others have ended up on the cutting room floor. So we do apologize for not concluding all of these prominent individuals. But what we did find was that Canadians are well represented in global health, and that their contributions are shaped by nation building at home, and that they've contributed valuably to Canada's role as a middle power. But by writing this paper, it was not just an exercise in collective backslapping. We also recognize that Canada remains a work in progress in 3 respects. So very briefly, the first is that what we call threats to health equity gains. To what extent do we say one thing in contributing to health and do another in other policy areas? So Canada is among the leading countries, for example, contributing to the drain of human resources for health from low and middle income countries. Canadian mining companies are widely criticized for their displacement of people and environmental impacts. So this disconnect between our commitment to equity and the complicity with transnational structures that sustain inequity deserves much fuller scrutiny. The second point stems from efforts during the Harper government to assert a different style of Canadian leadership. It was our Make Canada Great Again moment. And as we know, it has largely had the opposite effect. Our analysis shows that we have the biggest impact in the world when we build on our own history of prioritizing social cohesion and equity. And third, and perhaps most importantly, Canada has only started to redress the unjust treatment of our Indigenous peoples. Canada can never be back, and indeed Canada can never credibly claim any moral high ground in the world until we accept this truth and formally reconcile this nation-to-nation relationship. The inequities faced by Indigenous peoples remains a blot in our narrative of nation building. So let me turn now to my co-author, Stephanie Nixon, who will present our calls to action.
Minister Philpott, friends in the room and those joining us online, I am grateful to join this conversation taking place today on Algonquin territory. Based on the analysis introduced by Kelly Lee of Canada's ongoing nation building and our international position as a middle power, our team identified 5 lessons for advancing global health equity. The first is reconciling Canada's nation-to-nation relationships with Indigenous peoples and ending the related health disparities. Now, while ostensibly a domestic issue, the extent to which we understand the role of the Canadian government and of non-Indigenous people in the colonial legacy will influence the authenticity of Canada's voice on the global stage. To that end, we call for implementation of the 94 recommendations of the 2015 TRC report, including the 7 directly related to health. And Canada should mirror these actions abroad by increasing global health funding to support Indigenous peoples and the allies they choose to work with in the pursuit of commitments under the UN Declaration on the Rights of Indigenous Peoples, notably Article 24 on the attainment of physical and mental health. Second, Canada should amplify the message that diversity is a strength, a source of talent and insight, and not something to be feared or at worst criminalized. Notwithstanding the egregious treatment of Indigenous peoples and our ongoing struggles with systemic racism, Canada has worked hard to achieve a remarkable degree of social cohesion compared to other countries. Canadians often have a lived experience of such diversity, which embeds an openness of perspective that is ideal for leadership on global health equity. Third, we should reject a Canada First agenda that creates a false dichotomy between economic self-interest and global health equity. National health interests are better served through collective action that strengthens health systems, policies, and workforces worldwide. This includes adhering to WHO's Global Code of Practice on the international recruitment of health personnel. This also means better accountability mechanisms to address the harms arising from Canada's international role in non-health sectors, like mining, that have major health impacts. Fourth, Canada's contributions to global health are far-reaching and advanced on many fronts, but also fragmented and poorly coordinated, which limits impact. To that end, we call for a Canadian global health strategy along similar lines to the UK, Switzerland, and Japan. Central to this approach is a revived and improved version of the former Global Health Research Initiative, GHRI, whereby substantial common resources are available to government entities to encourage alignment around shared global health priorities. This framework should also invest in Canadian universities and civil society organizations to facilitate high-impact partnerships, plus create and support a global health career path within Canada to respond to the international regard for Canadian values. Finally, the spirit of these recommendations fits messaging we've heard from the Trudeau government. The challenge is to ensure that this government walks its talk. Words do not feed a table. To that end, Canada should use its G7 presidency this year to lead on global health, both by example, through concrete action to bring the Feminist international assistance policy to life, and also by facilitating collective action across the G7 countries to set a course toward realization of the Sustainable Development Goals. In closing, it's no accident that the Lancet chose to spearhead a Canada series now. On the global stage, progress on health is under threat, and Canada is uniquely positioned to become a more prominent global health leader by harnessing our distinct experiences, our diverse assets, and our core values. The challenge now is to turn these aspirational messages about health equity into impact at home and around the world.
Well, good morning, everyone. I would just like to say how proud I am as a Canadian to be here as we hear people like Richard talk about Canada's iconic reputation for global leadership. I think our challenge is reputation is a lag measure of performance. So how do we ensure that we maintain and build on this and don't have Canadian global leadership in health go from iconic to ironic? That's our challenge. So to address this, I'd like to talk about three things: possibility, reality, and hope. So on the possibility, the speakers and authors and Minister Philpott addressed the critical issue of addressing historical injustices here at home with regards to the Indigenous people. The challenge many Canadians ask is, can we actually support the funding of this while at the same time support health justice and broader development justice internationally? So for every $100 of our $2 trillion economy, we spend, for every $100 of our economy, we spend every year about a quarter. 26 cents per $100 is how much we spend on international assistance. For every $100 of our national economy, we spend on Indigenous issues about 2/4, 55 cents. So together, we spend 81 cents for every $100 on these two critical issues. No one can say that we can't do better. Norway spends on international assistance alone 20% more of its national economy, $1 out of every 100, than we do on these two critical issues together. So it is possible, and no one should tell us that it's not. So then let's talk about the reality. The government has made extremely important and necessary steps to address some of the key funding amongst the other issues on Indigenous cases. In the last budget, there was a 27% increase over the next few years. We have not yet seen that on the development side. So I'm going to look at the reality as a former McKinsey consultant, which says, rhetoric aside, what are the irrefutable facts? So the irrefutable facts are after 2 years, and taking into account the budget last year, this government is on track to commit 13% less of our national economy, of our share of national economy to assistance, international assistance, than the previous Harper government. It's on track to actually have the worst performance in the last 50 years. That's the reality. The 26 cents per $100 is 4 cents less per $100 in the Harper government, and is actually less than half than our peak under Trudeau Sr. The reality is actually a little worse than that, which is since 1970, for almost 50 years, Canada was a leader in international assistance. Good times and bad times, Liberals or Conservative governments, we always committed a greater share of our national income to international assistance than the OECD average. That changed for the first time in the previous government, where for about half the years we were ahead of the OECD average, and for the other half the years we were behind. So far, after 2 years, we are 100% behind the OECD average. In terms of the share of our national income we actually contribute to international assistance. That means we've gone from 100% leader for 50 years to 100% laggard today. That's the reality. And that reality has consequences in terms of where we invest. Up until now, key initiatives such as the incredibly important commitment to sexual and reproductive health and rights have actually only been funded by taking money away from other development programs. In January 24th of this year, Nick Kristof of the New York Times called us out on that, where he referred to our Prime Minister's pilfering policy of announcing new things by pilfering elsewhere. Ironically, that same day, we announced a doubling of education assistance with Malala at the World Economic Forum, except there was no increase in international assistance. Every cent of that doubling was, to use Nick Kristof's words, pilfered from other development programs, whether it's vaccines or education or food security. We actually don't know. What we know is there's been no increase. That is the reality. Let me turn to the hope. The hope is we have a budget on Tuesday. We have a G7 leadership opportunity. We have the strongest economic situation we've had since 1974. We have a government that's committed to progressive internationalism. The hope is we're at a position where our resources can match that rhetoric, and the opportunity is enormous. If you look around the room here, there's about 150 people. If you look at the faces here, and imagine that everybody represented 1,000 lives, 150,000 lives. That's how many more lives we could save every year if we went back from being a laggard to at least being on par with the rest of the OECD. If we increase this from 26 cents to 32 cents over the next few years, that increase would allow us to save 150,000 lives a year with the proven health interventions that many of you pioneered, and it would transform the lives of millions more. So that is today the possibility that we can address injustices at home while restoring or improving justice abroad. The reality that we're not there yet, but the hope that we will be soon, maybe even starting on Tuesday. Thank you.
Great, so I'll start firing questions after you. Again, a very data-rich paper, lots of stuff to discuss in there. But I want to start with Dr. Lee. I want to start with a really blunt question. So can Canada really promote health equity internationally if we can't achieve it at home? We've not achieved it with our Indigenous people. Isn't it hypocritical?
Well, I think we say we cannot. I think genuinely and with sincerity and with credibility, we cannot. And so I think our two papers are very interconnected, and that we show really that if, as much as we can achieve domestically, that is what we can offer globally. And so I do believe that, you know, these agendas and these two papers, which were written quite independently, say the same things. You know, we have the ability to achieve the things that we are identifying, and then we have the ability to share that with other countries. And I think that's where our strength lies. So we don't use the word hypocrisy, but I wouldn't leave it out. So
When I have columns, I only have 700 words, not 5,000, so I can't beat around the bush. So Dr. Nixon, the other thing that these papers have in common is they talk a lot about we're well-intentioned, but we're not so good on the action side. When I was reading your paper, this expression came to mind, grand parleur, petit faiseur, you know, big talk, little action. Does that describe Canada, or is that too harsh on the international scene?
I think it's an invitation for us to look at ourselves and the reputation that we enjoy globally and say, to what extent have we earned it, and are we continuing to earn it? And to what extent are there areas in which we're coasting along and maybe becoming a bit complacent in not being as critical as we should be at looking at the impact or the intent of our actions? This is something that a mature and thoughtful country and the fields that we work in should be doing, which is putting a critical lens on ourselves and saying, what are we doing well? But what are we not doing well? And in fact, what are the unintended consequences? What are the harms of some of the things that we're doing in the spirit of good intentions? And so what we're trying to do in this paper is to both celebrate where there are legitimate contributions, because there are, but to also invite all of us to be thinking much more critically about our place in the world and how we could be doing better.
And Robert, you had some pretty harsh words in your comments, Canada being a laggard, your groups...
reflecting a harsh reality there.
Yeah. But I want to talk about the flip side of that, the opportunity that you alluded to. Europe's a mess these days in global health. The U.S., the words fail me. There's a golden opportunity there for Canada to be a leader, right?
This is probably the greatest period since Pearson, when people are actually looking to Canada to provide moral and beyond that concrete leadership. And we saw that with the Prime Minister's extraordinary role during the Global Fund replenishment. We saw that in terms of at the World Economic Forum and elsewhere on the Education Fund. No, Canada is actually positioned to play an incredibly important role. But we do have a huge resource reality gap internationally. You know, the facts I laid out that actually we are presently worse than any government in the last 50 years is not what people perceive or expect. So we're kind of at a Wile E. Coyote moment right now where we're kind of out there flying, but it's not clear what's underneath us. And so this is the moment now and over the months of the G7 leadership and going into the Women Deliver next year for Canada to show we can put the resources and commitment to match that reality. If we do that, we have a tremendously important role to play at this point because people are looking for leadership.
Well, let me continue your Wile E. Coyote analogy. What's the anvil? I don't see a public outcry. Oh, please spend more on global health. What's going to push Canada to do this?
A couple of things. If you look through the history of Canada's engagement internationally, whether it was Pearson, whether it was Chrétien's decide to double aid at Monterrey, whether it was Joe Clark's role as foreign minister to prevent cuts to international assistance during the first part of the Mulroney government, that had to do with courageous leadership. It wasn't actually policy making by poll taking. It was saying, this is part of who we are as Canadians, and this is how we secure or help promote a more secure and prosperous and just world, and we believe in that. That's what it will take. It won't be people marching in the streets demanding this. It'll be the people debating around the cabinet table what's important and what are we wanting to be seen as and to be doing as Canadians abroad.
And Dr. Lee, could you expand on that a bit? How do you make this idea of spending more globally politically palatable?
Well, we just have to think back to the last few years and the kind of events that Canada has faced in terms of global health in its own risks. I mean, we just think of Ebola and MERS and all these other challenges in the world which come to our shores. And if you don't get the equity argument, get that kind of hard-nosed argument that if we can't just hide in this beautiful country of ours and expect the world to stay, the risks in the world to stay at bay. So we have to get out there and support other countries. It's a cliche now, but we are very, very globalized. Canada is one of the most globalized countries in the world. We're a very open country, and we want to be an open country. But if we do that, we have responsibilities to also be good citizens. And so that's what the argument I would make to people if if they challenge our arguments.
So back up our values with cash, in part.
Well, yes, absolutely. I appreciate the statistics. They're pretty stark, and you know, we're kind of riding on this myth of Canadians as generous. We're pretty we're laggards in this, and we need to really step up on the mark there.
And Dr. Nixon, you probably read the paper by Prime Minister Trudeau in the Lancet. It's very strongly worded for a politician. He doesn't mince words, especially on health and gender equity. Is that the way to go? Is that where our focus should be, on the equity piece?
Well, when I think about equity, I think about systems of inequality. I think about historic patterns that have given some people unearned advantage and others unearned disadvantage. And the fact that we have a federal government that's leading the way in thinking about patriarchy, sexism, the way that those historic patterns have given a lift to males over people who are not male, is fantastic. We should be paying attention to those historic inequities and doing something about it, especially because of the dire impacts that it has for health. But that's not the only system of inequality that matters here, nor is, I think, the government proposing that. You know, we've talked a lot today about settler colonialism, maybe not using those words, but that's the historic pattern that's given unearned disadvantage to Indigenous people and has also given unearned advantage to people who are not Indigenous and continues to, right? And so if we have a government that's interested in both of those things and how they intersect, that's great news. But it doesn't end there, right? There are other systems of inequality that matter here. Racism, heterosexism, et cetera, and it's our attention to the ways that those historic patterns give unearned advantage and disadvantage and how they have implications directly for who gets to be healthier and who gets to be sicker. That's what matters here.
But you have to have a priority, a message that where there's a priority, and that's as good a one as any. That's what I'm hearing.
Well, what I like is the idea that we're even talking about systems of inequality at all. Right? We've gone through a very long time where it's been proposed that what makes people healthy or ill is their individual behavior, that there's no such thing as structural determinants that actually shape the chances for some differently than others. So the mere fact we've got a government that's very interested in naming these is fantastic. That's the priority.
Good. So we have time for a couple of questions. If people have questions, raise your hand. There's a couple of mics running around. And while we're waiting for people to become less shy, Robert, I'll ask you, the 0.7, something Canada's proud of. We came up with this formula, but now we're laggards. How can we get back there, and how quickly?
Well, 0.7 is a very important aspiration, and Angela Merkel recently reached it with Germany. The UK's there, the Scandinavians are there. But I actually think our debate should not be, should we aspire to be the best right now? Our debate should be, are we comfortable being the worst? And I think we should say we're not. We should no longer be the worst in 50 years. We should no longer be laggards. We should at least step up, not to half of 0.7, and that would be a big step. And that's not easy. People don't realize when we look at Pearsonian International how tough that was. Lester Pearson had to have 6 tough cabinet debates when he was Foreign Affairs Minister to get the $50 million to launch the Colombo Plan, because finance was so bitterly opposed to us spending this money abroad, and plus ça change, plus c'est la même chose. So I think let's put aside the 0.7, because it's actually, looking at that, camouflages the fact it isn't about being the best, but about no longer being content to be the worst.
And Pearson didn't have to deal with the 24/7 news cycle, internet trolls, etc. It's a little harder to get your message out today.
He had to deal with a much more difficult fiscal situation. It was at the time of the Cold War, where people were having to rearm, where Canada had a debt of over 100% of GDP. It was much more difficult then than it was now. So with leadership, it is absolutely possible to restore liberal Pearsonian internationalism, in fact.
So I'll go here. The person with the most colorful sweater in the room gets the first question. So
Thanks,
tell us
Andre.
who you are and give us a question.
Thanks, Andre. Amir Ataran, Professor of Law and Medicine from the University of Ottawa. Robert,
Very good to see you.
Good to see you. It's
You
been
told
a
me a
long
lot
time.
about malaria years ago.
That was a long time ago.
Yeah.
Welcome back to Canada, and thank you for your comments, because I think you're bang on that Canada benefits in the world from a false, disingenuous, carefully confected image as a generous country when it comes to global health, and we are anything but. And I want to put forward one fact and then make one brief comment. It's not just the ODA side that is lacking. It is also funding for research on global health. And as recently as last year, CIHR, the Canadian Institutes for Health Research, said our total budget for global health research is $30 million. To put that in perspective, it's less than $1 for every Canadian person, and it is half the budget it cost for this beautiful building. Half. That's the amount of research funding we have for global health. So I think, and personally, I've changed my career not to work on global health in this country because I think it's an impossible, futile exercise with that kind of government support. So that's the fact, and this is the comment I want to make, and it's really directed to those at the Lancet, good friends like Richard, who we've known a long time and worked very closely together. It pains me to say what I'm about to say. I think in many senses you have done a disservice by this special issue, or at least by branding it the way that you have. Because just the headline, Canada's global leadership on health, perpetuates the myth we are leaders. And yet, as Robert points out, or as the statistic I've just given you from CIHR demonstrates, we are not leaders. And I think giving voice to the notion that we are is an anti-truthful interpretation of the facts that allows Canada to free ride on its image rather than its actual performance, the very crux of what Robert was talking about. I'll leave it at that. Thank you.
Thanks, Professor Adarand. We'll let Richard answer when he has the final word. But Dr. Dixon, could you talk briefly, research, how important is that? We didn't touch on it, and I'm glad it came up.
Yep, we're happy for the opportunity to reflect on the trends that we've been seeing around research. One of the new analyses that was offered in this paper was about global spending. Spending on global health research, in particular from CIHR. So to your point, it's far too small, right, in comparison to what's happening south of the border, in comparison to what's actually needed. What there is in place is a trend towards quite a vast increase in global health research spending by CIHR in particular over the last 15 years. Now, that's made possible by how little global health research funding there was 15 years ago, right? There was only room to grow up. But it has gone up, and it's gone up steadily. The other major challenge that you didn't raise, but we speak to quite clearly in the article, is the way that global health research funding is fragmented in this country and to the detriment of impact. And so where we once had a global health research initiative that tried to unite as much as possible the different arms of government that were engaged not just in global health, but global health research, so including CIHR, including Health Canada, including IDRC, we saw in the last 10 years the introduction of a new global health research funder, Grand Challenges Canada, that received tremendous funds. I received funds from them. I'm very grateful as a global health researcher. But what it did was not contribute at all to coherence, which is one of the problems around global health research funding in this country.
So let's finish up the way we did the other panel. I want to send people home with something actionable. What can we do tomorrow to make Canada less of a laggard, more of a leader in global health? And Dr. Lee, maybe you can start us off.
Okay, just very quickly, I think we could very much do with a global, Canadian global health strategy like other countries. A few countries have already grappled with this. It addresses the fragmentation issue. It could set, I think, priorities in terms of research, in terms of aid funding, and in terms of training. We have such an amazing group of young people in the country who desperately want to work in global health. So we need to really support them, and I think this global strategy could help that.
Robert?
I think we just need to make sure that our commitment of resources matches our collective aspiration. Last year, the government laid out a 10-year, $75 billion increase in the military. The same week, it announced the funding framework for development, which was essentially no funding and no framework. But I hope that was simply an issue of, given all the challenges fiscally, they weren't able to do all they wanted to do. No government is. Now we have the opportunity in this next budget, the G7 and the following budget, to make sure that the rhetoric and the resources are matched. And then, as you say, we actually have a historic opportunity to make a global difference in health.
And Stephanie, the final word?
With pleasure. I have a message for the field of global health. So this is for all of us who see ourselves as global health policymakers, activists, advocates, researchers, educators. As you've seen, the issues around Indigenous settler inequities, around colonization as a determinant of health, was absolutely central to our analysis of Canada's contribution to global health. That is highly, highly unusual in global health. We typically, in this field, do not connect the dots between our interactions in global health to our Indigenous people in Canada and to colonization as a determinant of health. It was presented today as if that's almost normalized, as if, of course, we're talking about colonization in the context of global health. That is not the case in the field in which I've spent the last couple of decades. And so this is the invitation, this is the imperative to all of us working in this sphere to look at how we do what we do. The courses that we teach in our universities, the research that we conduct, to what extent do we understand the role that colonial processes play in shaping what we're doing? Most of us would say our research is not about colonization. It doesn't matter. To what extent are our practices, our day-to-day policies, the questions we're asking, actually rewriting and they're reinforcing colonial patterns that have been around for decades that we just cannot see, those of us who are not Indigenous, because we too are colonized. That's the invitation.
Well, thank you for bringing together the whole morning in some very lucid comments to end. We're going to have some closing comments, but while Richard's coming up, please join me in thanking our panelists. Thank you.
Well, thank you very much, and I just want to endorse Stephanie's last comment about colonization. I noticed from the news media that your Prime Minister is currently in India, and anybody who's read Sashi Tharoor's absolutely brilliant and blistering book, Inglorious Empire, will see how the history of colonization by my country, the United Kingdom, and its literal extraction of resources over several centuries of India, leaving nothing constructive behind. The claims of whether you're talking about railways, democracy, newspapers, or cricket are brilliantly deconstructed in Sashi Tharoor's book, shows very powerfully that India's predicaments today can very much be laid at the door of my country's history of colonization. And I think linking those histories to global health is absolutely correct. The British, writes John Ralston Saul about Brexit, which you may have heard of, in the new prologue to his updated and just published book, The Collapse of Globalism. The British, he says, had a nervous breakdown and combined delusion with hubris. So, as I come to this podium to close this discussion, I should, in my delusion and hubris, express a note of humility, and Amir has perfectly set the scene for me to do so. So we have done a disservice to you by publishing this series, he says. Well, the series certainly challenges you as a country, whether it's political leaders, but actually across that tripartite social contract, whether it's the health professions and the public, to do more. The series does challenge you to do more. But, Amir, I don't fully agree with you, respectfully. I think it's right that you challenge your own country in the way that you've done, absolutely. But as an outsider, and I really speak as an outsider, I have been a great admirer of Canada's moral and practical, political and programmatic leadership in health over the years. If I look at the contribution of CEDA when it existed, when I look at the contribution of CEDA, I know, that's the point you say, exactly. And I say that because I was sad that CEDA was disappeared in that way, because it did make a fantastic contribution, but so does CHIR. IDRC is supporting a series of papers we're doing on children in conflict. It's supporting a commission that we will publish later this year on the global and regional consequences of the Syrian civil conflict. We couldn't get funding from anywhere else. Who stepped in? Canada stepped in. So Canada's leadership in funding the very things others don't want to fund is tangible. When President Trump, or 45 as we should call him, stepped back once again and introduced the global gag, it took courage for a G7 political leader to step forward and talk about sexual and reproductive health and rights. It is a very divisive issue, but to actually write, as he does it in the comment, he doesn't shrink away, as some do when they talk about sexual reproductive health and rights, they talk only about modern contraception and family planning. But he explicitly talks about the provision of safe abortion care and post-abortion care. That's courageous in our conservative world of global health today. And he should be applauded for that moral leadership. Yes, do more. Yes, commit the money. But that is a fantastic start, and I commend him for that. Now, this series does document what I think are Canada's successes. There has been political commitment over the years to achieve universal health coverage. There has been money invested, and people have led that, and we should celebrate that. But what this theme issue we published today also makes clear is that values matter too. And Canadian values have been critical to that success and need to be renewed around equity, solidarity, diversity. You've heard them: inclusivity, universality, global citizenship, social cohesion. This is the unique constellation of values that you have created from your history and your cultures. And the idea that health for all Canadians is one of your critical missions has been crucial for your nation building. And yet the series doesn't step back from saying that within this story there is a warning that its successes at home and abroad cannot be taken for granted. Indeed, they are under threat. As one of the papers says, universal health coverage is not easy to deliver, let alone maintain. It's not a destination. It's a permanent aspiration. So today is a clear opportunity for stronger leadership from Canada globally, as the country to the south of you steps away from the world and advocates more guns in our schools, not fewer. As the United Kingdom struggles with its role and identity in one of the most bizarrest moments in its recent history, while Europe redefines itself and its future as India and China grow to rebalance geopolitical power and governance in the world today. This can be Canada's moment, acting confidently through its alliances and multilateral collaborations, as it has done, even in recent years. I cite Muskoka again. And at home, tackling the social determinants of health, notably for its Indigenous communities. Now, we are not publishing in this, getting on the plane and going back home. We are going to follow and support and hold accountable, and I want to say a word about that, the meaning of that idea of accountability in a moment. We're going to follow up on what this series is saying and suggesting. Accountability is not a bean-counting exercise, as Colleen rightly said. It's about three very powerful ideas. It is about monitoring progress, measuring progress. But then it is about something core to our idea of democracy. Because accountability is about collecting data and then finding participatory democratic means to bring everybody in society together to discuss the meaning of those data and what we do with them. And the third dimension of that notion of accountability is action, fixing the problem. Where did that idea of accountability come from? It came from Canada. It came from the Commission on Information and Accountability, co-chaired by the Canadian government. It was Canada who defined the 21st century meaning of accountability. It was Canada that put the democratic notion of what it means to talk about accountability at the forefront of global health today. John Ralston Stall ended his book by saying this: Canada is on the leading edge of how to build a society with a constantly evolving set of citizens and cultures, deeply devoted to an egalitarian idea of itself. It's time to turn that idea into a motivating social and political impulse, to turn that impulse into a series of initiatives that can deliver action to change the lived experiences of your communities and communities worldwide, and to turn that initiative into an inspiration for other countries that want Canada to lead. Thank you for today. It's been a pleasure to see you.
Richard, thank you for that animated and inspiring conclusion to what has been a thoughtful and insightful series of discussions. I thank all of you for being here. Minister Philpott, let me reiterate, I think, everyone's gratitude to you for not only opening our session with such impact, but also staying throughout the morning to participate in these discussions. It's a great indication of your commitment to these issues and to this community, so thank you for that. Global Affairs Canada has been our a funding partner in putting this session on today. Let me thank again University of Toronto's Faculty of Medicine and the Lancet for the collaboration, and to you all for joining us here. We'll hold Richard to account for his commitments of follow-up, and hope that they will see it fitting to come back to Ottawa in due course for us to continue this conversation in light of decisions that may be taken even in the next few days. There is a survey on your chairs, which I'd ask you to fill out. There is new technology in the building that allows us to electrocute each of you who do not fill out such a form before you depart. So please do that, lest you test our mettle on this. Thank you to all those who are joining us from elsewhere in the world, and we look forward to having you participate again here at one of these events. Thank you.